it's a highly complex area, clearly. So if I can just summarize, and please correct me if I'm wrong, CLL patients, when they're diagnosed, will fall into, generally speaking, one of three equal categories. Either they won't need treatment for maybe for quite a long time, perhaps never, for whatever reasons. Secondly, they may need treatment quite soon. Sometimes almost immediately within a very short period of time. And the third category, and this is the one I think we're concentrating on here today, are those that will be put on watch and wait, medical monitoring. And what you're trying to do is to identify those people who are most at risk and who may require treatment in the near future. If you can identify those, what sort of action would you be taking? Can I mention that to David first of all? As a clinician, you see these people who have all these genetic factors, 17p deletion, TP53, and so on, Notch1, plus these two new areas. What would you be saying to them at that point?
So the first thing is generally my view is that you can never have too much information. Knowledge is all in all aspects of life. So the first thing is you can be much clearer with an individual as to what their particular circumstances are. Do they have a disease that's likely to remain very stable, or do they have disease that's going to progress fairly soon? And that might influence the individual thoughts about their current situation, the situation going forward. There are a lot of new diagnoses of CLL. So in Hull, we get about one a week. And for people who have very, very stable stage A disease, we'll often discharge those back to primary care for the real reason that we just don't have facilities to follow all these people up. If you know somebody's at very high risk of progression, you might want to keep those under closer supervision, see them in hospital more frequently, or you could ask the GP to keep an eye on them, but with much clearer instructions about you need to check every few months rather than less frequently. In terms of early intervention, that might be the way things are going, as Jim mentioned in his last slide. But we still need sort of clinical trials to really prove that early intervention with high-risk markers is worthwhile. And that's because even though our therapies have moved on a lot, which is fantastic, all treatments do have side effects, and we have to be certain that early intervention is beneficial rather than detrimental.
Thanks, David. Jim, if I can ask you a question, which has come in while we've been speaking. Are the risk variants 6 and 10 that you've been speaking about, are they relevant to SLL as well as CLL?
Well, we don't know that, so we haven't looked at that in our particular study. It's entirely possible that they may be, however, but I think that would be, obviously we require studies to have a look at those, but that's not something we've looked at.
Thank you. And how far away do you think we are from having what you've been discussing as part of the toolkit, if you like, for clinicians?
Yeah, so it's one of the issues really is, getting tested for these things. So at the moment, local trusts and local, and treating clinicians will test their patients or recommend testing for various things like P53 mutation and ATM deletion. And I think what this does is it allows clinicians to recommend these tests. So, as I mentioned, they're very easy to do. And in fact, a lot of centers now are using whole genome sequencing. And it's likely here in the UK that whole genome sequencing will, at some point, over the course of the next 5 to 10 years, become essentially standard for most cancer patients. So this technology will pick up these variants, and in fact every other variant in the human genome. So that information will be available as routine to the treating clinician. So it's really about us giving, the clinician and the patients the tools to understand a little bit more about the leukemia and make the best decision for that patient. As Dave mentioned, information, knowledge is power, and it does make the decision hopefully a little bit easier about how to sort of treat the patient and when to treat the patient.
That's very encouraging. I want to break in for a second here now, because we've got the results of the survey that were earlier on in the program. So if we could have those now, and then we can perhaps have a look at them.
So, as possibly I might have guessed, our sort of viewers' experience of monitoring is very variable, and I suspect this is largely dependent on how units approach it, whether people are being discharged without any support. Some parts of the country offer remote monitoring services. There's one based out of Leeds. I suspect there's others where essentially there is an automatic recall. So that really highlights the sort of variability in this approach around the country. Okay. What do you think, Brian?
Yeah, I'm just looking at the second question now. What symptoms would make you feel that treatment for CLL was needed? I think that those are in line with basically what you mentioned earlier on.
Yeah.
Frequency of infections is a key one.
Yeah, the lethargy, that's a key one, and the lethargy and fatigue is very difficult. Just obviously fatigue can be extremely disabling. The problem we have is that we can cause fatigue with some of our treatments, and I've found from experience that over the years making fatigue better is difficult. We can give treatment to make the blood test look better and shrink down lymph glands, and we can improve people's energy levels and quality of life, but disabling fatigue is extremely challenging.
Sure. And then the question 3, we had several questions coming in about this. Mm-hmm. How would people feel? Let's assume somebody's 30 or 40, which I know is unusual, but there are people certainly under 60. Yeah. We have a very active under 60 group,
yeah,
who are extremely active and vocal. How would they feel about being told that they had very poor prognostic markers?
Yeah.
How would you, as a clinician, how would you handle that?
Well, again, it's my role as a clinician to help someone understand what their particular circumstances are, what the diagnosis is, and what that means for them. So, and if there's features of someone's CLL that's associated with it being more likely to progress, then it's my job, obviously, to explain that. And I can see the majority of respondents would seem to feel that way, would rather know what their particular circumstances are. 8% feel it will be very depressing, and I can understand that as well. But again, how that's managed is dependent on the support that people like myself can give, and also specialist nurses teams, and many units have other ways of supporting people. But yes, I can understand that being difficult.
Yeah, yes, it is. But it's interesting how many people are positive about that.
Yeah.
I find that quite surprising and quite welcome.
But no, I'm not surprised about that, actually. I find people genuinely, obviously want someone like me to be open and honest with them, which is fine, and to be fully informed.
Okay, fine. Thank you very much for that. Let's move on a little bit. What do you think, Jim, is the next stage in research? Are there other markers that you're looking for that can be found that will sort of hone what we have, or the tools we have at the moment, to make them even better?
Yeah, I think so. I mean, as I mentioned in my talk, we've, as a community, scientific community, we've identified over 40 of these variant markers in the genome that associate with risk of CLL. We've, through this paper, Dave and I have discovered the first 2 of these markers that associate with risk of progression. There will be others. As we discover others, their individual impact is likely to be less powerful. So essentially what happens is, whenever you do a study like this, you find the low-hanging fruit first. So these 2 markers both increase risk of progression about 2-fold. So they double risk of progression. So as we find more, and the way we'll find more is by adding more and more patients to our study. So the data that we've already got, we can use as a foundation and add in more cases, and that's exactly what we're doing. So what we'll do is inevitably find more markers that will refine the model and make the model essentially more and more accurate. And that's what happens. These models just get progressively more and more accurate. And obviously that's what the patients want, and I think that's what the clinicians want. It helps them, manage the situation much better. Excuse me. And there will also be, interestingly, these genetic markers. There will be some genetic markers that impact on survival post-treatment as well. So we've been talking very specifically about this period from first diagnosis to the point of first treatment. So there will also be markers that impact on outcome post-treatment. Of course, we know at that point in disease that these acquired alterations like P53 and ATM, they have a big impact on how the leukemia responds to therapy. But there will certainly be these pre-existing genetic variants that impact on disease. So yeah, that's essentially what we're doing, just trying to make these models more and more accurate as we go forward.
Yeah, thank you, Jim. Interesting global question here. Does this knowledge that gaining move us any closer to a cure for CLL?
I've got an answer to that. So I've got a metaphor. So curing CLL, because I'm a hill walker. I'm one of these people that goes out with a rucksack in the rain and stuff like that. Like climbing mountains, and so curing CLL is a mountain that everyone's trying to climb. And the work that Jim and I have done, it's another sort of step carved in the side of the mountain, moving upwards. And there's hordes of people like Jim and I around the world, all trying the same thing. And all these sort of contributions, so the small contribution that Jim and I have made, and other people that you've heard speak in these fora, it's all carving steps upwards, so pushing treatments forward, investigating new combinations of drugs, and maybe using new combinations of drugs in people, subgroups identified by certain tests. It's all steps up this mountain. And then one day we'll all get to the top. And that's been done for other diseases, and it'll be done for CLL.
How close do you think we're to the top?
We're on our way.
Okay.
Brian, the other way to think about this that I think is relevant, and COVID provides quite a nice sort of analogy to this, is that that a lot of these human diseases before we get to a point of cure in eliminating the disease from the patient, many of them can be converted from aggressive diseases that kill patients to indolent diseases that are eminently treatable, that people can live with. And if you watch the PM's COVID briefing over the last several months, you'll see that that's the model they're taking with COVID. They focused initially on reducing the death rate from COVID. But the message that's coming across now is that, at least in the short term, we're going to stop people dying from this disease. And if we can do that, then we've made a big step towards dealing with it at a societal level. So I think something like CLL, certainly, that's eminently achievable for CLL. So even prior to a cure, there's potentially a situation where we can stop people dying from this disease and people can live with it. Albeit I completely accept with changes to their lifestyle possibly, but that's certainly something to consider that I think hopefully would be viewed positively by a lot of people. And again, as Dave says, the work we've done adds a little bit towards that.
Excellent, thank you. It's a question of managing, isn't it, really? Managing the disease so people have a normal life expectancy and as normal life progression as possible. And the development over the last 10, 15 years has been astounding, I think. We have time for a couple more questions. We're running out of time, but these two questions are linked together. Does your work indicate that CLL or the predisposition for CLL can be inherited? And if that...
Yeah, so the simple answer to that is yes, that all human diseases have a genetic component. So I'm a little bit nervous about using the word inherited, because what people understand by that often is that if they've got a parent who's got the disease, they might inherit the disease from them, but it doesn't quite work like that. So if I can put it into sort of lifetime risk, this is a good way to think about it. So the lifetime risk of any individual developing CLL is about 1 in 175. So 175 people, one will develop CLL. So if as an individual you have a first degree relative, and I mean either a parent, a child, or a sibling who's got CLL, then your risk is approximately doubled. So it goes from 1 in 175 to about 1 in 85 or so. So it's still extremely unlikely that you will develop CLL during your lifetime. Just to put it into context, if we think about some of the other cancers, human cancers, so the lifetime risk of a woman developing breast cancer is 1 in 7. So if you have a first degree relative who's got breast or indeed ovarian cancer, the risk is approximately doubled. So it goes to about 1 in 3.5. So CLL really is, when you think about it in those terms, having even a first degree relative, it increases your risk certainly of getting CLL, but it still doesn't make it likely that you will get CLL. So these are, cancers like CLL are still, fairly rare diseases. So, of course, the situation is slightly different if you've got lots of first-degree relatives with a disease. Then what's almost certainly going on there is that there is a variant in the genome in that family that on its own causes very high risk of that particular disease. And, of course, we see those with breast cancer. So families that have, say, a BRCA1 or a BRCA2 mutation in their families, and they can have several individuals who've got breast and ovarian cancer. In those families, the lifetime risk of developing breast or ovarian cancer can be as high as essentially 100%, depending on the mutation. So that's different if you've got lots of first-degree relatives with a cancer. But really, just having one first-degree relative, as a general rule, approximately doubles your risk. But for something like CLL, the baseline risk is actually very, very low. So even doubling it still makes it extremely unlikely that you will get CLL.
In that case, is there any benefit, do you think, in future for testing relatives of CLL patients?
So not unless you've got lots of individuals in your family with CLL. If you've got lots of individuals, then yes, but otherwise, no. If you've just got one father, one sibling with CLL, I would argue it's not. And I'm hoping Dave would agree with me on that.
Yeah, you'd have to think very, very carefully. So what you're saying is the merits of screening people who are thought to maybe a bit increased risk of a disease. And screening programs are used, as you'll know, for certain cancers. But if you're going to screen for something, you really have to be certain that looking for something that is asymptomatic early in its course, that's a useful thing to do in terms of either being able to institute early treatment or some other action. So you could do that, and you would find some people with asymptomatic CLL or the precursor of CLL, many of whom would never need treatment, but there'd be a flip side to that of then somebody being told that they have a cancer and all everything that follows from that. So it's not standard clinical practice to advise screening of family members for those reasons.
Thank you, David. A couple of other questions come on now before we wind up. We're a little bit over time. Who decides whether and when to carry out prognostic assessments?
So at the moment, it's really driven by the reference laboratory that's used, and that does vary slightly around the country. But there's a standard, there's a core panel of tests. So most places would now do what's called FISH or high throughput sequencing to look for an abnormality in something called TP53 or 17p. I think until relatively recently there was a degree of inequity around the UK in terms of accessing these tests, which I know has been highlighted by organisations like yourself. I think and that's largely gone now with how some of these new drugs have been approved by NICE. So yes, it's driven by the regional reference laboratories, and as with all things, there's a price. So the IGVH test that's been mentioned 2 or 3 times, that is not widely accessible because I believe it's not uniformly reimbursed. So you're then dependent on whether you use a centre that's got a particular interest in doing that or has some sort of mechanism for doing it. So, for instance, the laboratory I use doesn't.
Okay, thank you. One question, if I can, on COVID, which of course is bound to be topical. This one's for you, David, and it's really to emphasise something. How do I behave? I've had my second vaccine. In light of the study that seems to indicate that we may not, that CLL patients may not respond well to vaccines.
Yeah.
Is an antibody test advised?
So, so I knew this would come up. So I had a quick dig around last night. There's another paper just in press in the journal called Blood, produced by an Italian group, who've performed the obvious study of looking at antibody responses in a cohort of CLL patients. And they show that the antibody responses overall in CLL are reduced compared to the general population, with some variability according to whether you've had certain treatments, but with the caveat it's a relatively small study. So if you've had both vaccinations, that is excellent and definitely the right thing to do. We don't know at this point that has no effect. That is likely to have some effect on the immune system and is likely to be helpful. And if you're unlucky enough to get the virus, it may well take the sting out of it a bit and hopefully just have a mild illness. In terms of how you conduct yourself in your life, that's very, very hard. So obviously the government advice on shielding, it's a fairly black or white thing, isn't it? You're either told to shield or you're told not to shield. And I'm sure a lot of people listening to this will have had letters telling them they no longer need to shield. COVID is going to pass at some point. So the pandemic is going to pass. All pandemics in history have passed. And this eventually will pass. And COVID will become some sort of lower level endemic problem, a bit like flu in the way that Jim has said. It's down really to an individual's preferences and their perception of risk as to how they live their life in the next year or two. The advice I've been given to my patients is essentially to think very carefully about going into places that are crowded that you may not necessarily have to go to. So it's nice to go out and have a meal with friends in a crowded restaurant and have a nice time. Maybe that's something that you should knock down the line into maybe next year. Same with supermarkets, same with other crowded places. But there's and that's the line I've been taking, and most people have been receptive to that. However, some people are very keen to resume their lives. It's a slightly measured decision. And in terms of antibody tests, I don't think that really helps. I don't think the sort of Jim's colleagues that are into infection and immune responses, I don't think anyone really knows how you can accurately predict how good a response you've had. And an antibody response is only one part of the immune system. The immune system is like a many-tentacled octopus, or it's got thousands of lots of different arms. An antibody response is one arm, and there's lots of other elements that are much harder to test for. So I don't think I've answered your question really.
Well, I think you've covered it pretty well. Thank you. One final question, and then we'll wind up.
Yeah.
The work that you're doing, both of you, but particularly Jim, does it throw any light onto Richter's transformation? Does it? Could it forecast Richter's?
Yeah, that's a difficult question. So we didn't look at Richter's in our study. I don't even know how many Richters we have actually. We didn't set out to collect that information. So we do know that some of the CLL risk variants, these 40 or so risk variants that we've discovered for CLL, some of those, a very small number, are also risk variants for Hodgkin lymphoma. I'm not aware of, if I'm remembering correctly, any of them being risk factors for non-Hodgkin lymphoma. What I can say is that there will almost certainly be some of these constitutional variants that do predispose to Richter's transformation. But we haven't looked at them in our study, but they will almost certainly exist. How strong they are, we don't know. The study will need to be done to look at those. So I suppose the sort of underlying message is that genetics, human genetics, and these variations that we're born with, they do impact on lots of things. Every human condition, heart disease, diabetes, any complex human disease, those variations in the genome have a big impact on why some people get, for example, diabetes and other people don't, or heart disease, or whatever it might be. So almost any human trait, you could argue, has an impact, or has a contribution from genetics in terms of its risk. But unfortunately, we haven't looked at Richter specifically in our study. So there's always more work to do. Always more work, Brian. Yeah.
Surely there is always more work, isn't there? Well, I want to thank you both most sincerely for giving us your time. And I know you must be extremely busy at the moment. In fact, at any time, it's very much appreciated. We wish you well in your research and look forward to speaking to you again, maybe in a year or so's time, when you have some more information to give us.
Excellent.
That'd be lovely. Thank you for asking us, Brian.
Yeah, thanks very much.
Best wishes to you and everyone listening.